It's Dr. Deukmedjian. It's 12 o'clock, and we're getting ready to start a Deuk laser disc repair, L45, L5S1. That's a patient who has two herniated discs, L45, L5S1. She's having back and leg pain on the right side, which is what most people with herniated discs, when they have symptoms, they're going to have back pain and leg symptoms. And whether they have symptoms in the leg on the right side, left side, or both sides, depends on whether the right side, left side, or both sides of the disc herniation are symptomatic. There's really very little control the patient has over that. Lay still. It's Dr. Deuk, okay? You're doing great. Just lay still. You're going to feel a little stick and burn. That's normal, okay? I don't want that to bother you. Just lay still. Everything is okay. I'll let you know if we're having any problems. If you feel any pain, you just say ouch, and I'll take care of it, okay? So we're giving her some numbing medicine right now in the skin. That should help. You're doing great. That burning in your arm is just the propofol medicine usually going in your IV, so don't worry about that. That's normal. I'm Dr. Deukmedjian. We're going to get started here. I'm giving you some more numbing medicine, okay? Try to make you more comfortable. That should be not in my way, but let's get a shot. Let's go lateral. You're doing great. Everything is okay. I need you awake so you can help me in the beginning. All right? I'm talking to the patient right now, not the audience. I expect the audience to be awake all the time. That's not a good picture. That's much better. Thank you. Shot. By the way, you lined it up, I think, pretty good. Interesting. Shot. You're doing great. Everything's okay. Shot. It's too far south. Shot. 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 Definitely on the facet joint. Want to be just a little bit north. I think Jordan's done a fine job of lining things up, I think. It's kind of hard to tell. It looks like the pedicles are superimposed, right? Right? And we're seeing down the disc space. We need to be just a tiny bit more north. Shot. Shot. Now when I say shot, folks, I'm saying shot as in take a picture. That's just the way I was brought up. Shot. And every doctor says different things, but shot. It's basically take a picture with an x-ray. Okay? So I'm up against the facet, and I'm not able to get past it. So I'm going to have to adjust what I'm doing a little bit. Shot. Shot. She's nice and comfortable. I love it. Did you ever check Shot Santiago's records out? He just uses propofol. Shot. 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 So I'm trying to get around the facet joint pretty close. And everyone's anatomy shot is a little different. Shot. 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 You're doing great. Shot. 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 You awake? All right. Dr. Deuk here. We're just getting everything in position. And then we're going to put you to sleep, okay? Are you comfortable? Do you feel any pain? Where? On the left side of your back? All right, let me see the lateral again. The lateral is there. I think we need to be a little more medial. Let's go back to a lateral view. Let's go. You do have a bit of arthritis in this facet joint over here that's deflecting us. Are you comfortable? All right, good. That's the joint. Shot. Here we go. Shot. Are you awake? Let's go, let me get a little bit closer. Where do you feel that? In your back or your leg? In your back. All right, AP. So that's perfect. Couldn't do better. She's not jumping around or moving, but she's still responsive and she can give us accurate information. So for those of you watching the surgery for the first time, we do need our patients awake, in the beginning. Just the back. Go ahead and give me a lateral view. You're doing great. Wait, shot. You're fine, everything's okay. Give me a shot that I can use. Good. Incision. Shot. Shot. Good. Nice job. I want to bring it out just the tiniest bit. Shot. Still in good position. So we're making an incision now. Incision. It sounds funny. I don't know why. But an incision is where you cut into something. In this case, it's the skin. And the incision for the Deuk laser disc repair endoscopic surgery is 7 millimeters in the lower back. It's a 7 millimeter incision. Shot? So now we're going to get to the next disc. I think you can improve that a little bit with some WAG. You see how the pedicles are offset? Jordan, you see what I'm talking about? Give me some num-num. Nope, that's for the skin. Yeah, I think you need to move south a little bit. That's a perfect view down the disc, but you're too far north. Just a little bit south. Just lay still. We're going to put you to sleep soon. Shot. Is that it? All right, that's good. I think we can do a little better with some WAG. Shot. I think yeah. Not bad, Jordan. Not bad. Shot. We can live with that. Work with that. Shot. Yeah, that's looking good. Shot. 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 Now this young lady was here last week. Shot. And unfortunately for her, our our cable for our laser broke. Shot. Right before her surgery was supposed to start. Shot. And so we actually had to shot. Are you comfortable? Any pain, shot?
Yeah, you feel pain down in the back, honey? Tim? Yeah.
In the back?
There you go.
Shot? Yeah. So as I was saying, the pedal cable was sheared in half. So we had to cancel her surgery and reschedule it. So for those of you watching, you can see we've made an incision. We've lost about 3 or 4 drops of blood. And that's pretty much all the blood we're going to lose for the back surgery. So the Deuk laser disc repair is revolutionary surgery in the fact that it saves blood. And it's also such a small incision that patients don't need narcotic painkillers after surgery. They just take Tylenol or anti-inflammatory. Are you awake? So we'll test and then we'll put her to sleep. Are you comfortable? All right. Do you remember where your pain is in your back? Okay. All right. Do you see that, folks? She tensed up and she's moaning and groaning. How bad is that on a scale of 1 to 10?
1 to 10.
What's the worst it got? 10? Is that where you tip 15? Is that where you get your pain?
Yes.
Okay, so that's concordant at 5-1, 15 over 10. So unfortunately, and Dr. Arcos knows better, but unfortunately many doctors, about 95% of them, don't understand that the spinal disc can cause back pain. They don't believe it causes back pain. As a matter of fact, most neurosurgeons don't believe that a disc herniation causes back pain. And hence, here we are, sitting in a car, trying to go somewhere, and our wheels are spinning in the mud. We can cure back pain if doctors would just understand the disc not always causes back pain when it's herniated, but it can cause back pain when it's herniated. Just about every human being alive over the age of 40 has a herniated disc, but very few people have back or neck pain from the herniated disc. So those people with chronic back pain, chronic neck pain, they have axial component, which is pain in the center of the spine, and they have a herniated disc. Those herniated discs are usually causing the pain. But right now, nobody believes that. It's like if there were ghosts, and they really did exist, which they don't, but let's say they did, and they did bad things, well, you would never be able to solve the ghost problem unless you first believe in ghosts. But you're taught not to believe in ghosts. At least I was, my generation was. The truth is that most neurosurgeons and doctors, orthopedics, are taught that discs don't cause pain. But the disc is a joint, and just like any joint that gets injured, it can cause pain. Are you all right? You feeling better? All right. How bad is that on a scale of 1 to 10? What's the highest? 9? All right, that was L4-5. Is that where you typically get your pain? All right, you get to go nighty-night. I want you to count from 1 to 100. Count out loud. So if you look at the second injection I did, the dye, you can see a large herniation there indenting the dye. You can see a massive disc herniation. That's a grade 5 annular tear and herniation. That's huge. That's at the L4-5. So even though the L4-5 is a huge herniation compared to L5-S1 shot, it's the L4-5 is not as painful. Okay? So what do we learn here? The size of the herniation does not correlate with the amount of pain that a patient has from a herniated disc. Very, very important. They have nothing to do with each other. So surgeons that look for large herniations as the cause of pain are wrong to do so, because the pain from a herniated disc is due to inflammation in the annulus. That's what my discovery and my contribution to medicine. It is not due to pressure on the nerve root like so many people mistakenly think. Pressure on the nerve root rarely causes pain. It mostly causes weakness and numbness and tingling. Shot. The pain in the distribution of the nerve root is mostly due to inflammation of the nerve root from the herniation. All right, the tip of the dilator is now sitting at L4-5, and it's right at the herniation. So I'm not going to enter the herniation and the tear until my anesthesiologist tells me the patient's ready, because otherwise it's going to be very stimulating for the patient. So it's best to wait until she's sleepy. Let me know whenever you're ready. So you all see the tip of that dilator? It looks like a pencil coming in from the right side to the left. It's literally sitting right where the dye ends. The dye is wrapping around the herniation. That's a big herniation. Whenever you're ready. And if you look at the MRI, the herniation's not that big on the MRI. Okay? So why is it big here? Because in MRI you're laying flat on your back. You ready? This is a more normal lordotic position of the spine. Yeah. She's ow-owing, meaning that this is definitely the source of, pain source. We're going through the tear into the disc. Take this. Okay. So we're at L4-5. You're going to have to straighten that out. Perfect. I went through the tear. I could feel it go through the tear. And as a result, now we're inside the disc and we went through the tear. So people wonder, how do you do this surgery? Well, what's really cool about the surgery is there's no damage to any of her body except the skin where I cut 7 millimeters. That's the smallest surgical incision there is in the world. And I passed through the muscles and the fat, which don't get hurt at all. You wish the fat was hurt so it would go away. But unfortunately and fortunately, none of this does any damage. It does a spreading motion. It spreads tissues apart. And because it spreads the tissues apart rather than cutting them, patients recover almost instantly from the surgery, like within 24 hours. And of course, at the level of the spine, I'm not taking any bone out. We're not doing a laminectomy shot. We're not doing a foraminotomy. We're not taking the bone or joints out like other surgeons do. Every other surgeon that operates on the spine takes out the bones and ligaments of your spine, which you don't want done because it's going to weaken the spine. This transforaminal type surgery, you go through the foramen so there's no removal of any bones or ligaments. All right. So take the fluoro out, watch your head. Let me have the grabber. Did we ever find out? I was going to call you last week.
No, I mean, yeah, we fixed it over here, sir.
You got to try to pull the fluoro back a little bit.
Yeah, we fixed it.
What was the problem?
It was stuck in the entrance, but we cleaned it better, and then I used that as well. What's good? What's good?
Well, that means there was tissue, right? That's not good.
I think was tissue. It was like I think when they fixed it,
Yeah.
I think was like a kind of bended, and I just
All right. She okay? All right, so let's bring all this stuff here, and let's put this here. So any questions from the audience so far about this endoscopic spine surgery? This is the future of spine surgery, by the way. Unfortunately, most doctors don't know how to do it. Most spine surgeons have no clue it even exists because they're not taught to do it during their training. This takes a very special skill set and equipment that most surgeons have no clue about because they're not taught about it during their training because it's so new. All right, wow, there's the tear right there, and that's part of the herniation. Laser? Is our next patient here?
they should be here.
Huh?
They should be here.
Find out, please, and let's get them ready.
We told them that.
We'll be done in about 15, 20 minutes max. Huh?
Jordan, you can turn on.
So Luis, so all we had was a burnout bulb on that other.
No, it was
the-
a fuse. Was
a
the
fuse.
Yeah, the fuse blew up.
So we replaced the
Yeah,
fuse.
we replaced the fuse. This is the machine.
Good job.
We
Nice
have two
work.
machines, so yeah.
Nice work. Thank you. Let's get them ready because we're going to be ready for them in 25, 30 minutes. Make sure they're gowned and IV and everything ready to rock and roll. All right, so what you're seeing is the silver is the inside of our tube. This is called the tubular retractor. In surgery, we use different kinds of retractors. One type is a blade, which we used in the last surgery. In ACDF, we used blades, and this is a tube. So there's different kinds of retractors used in spine surgery. This is a tubular retractor, so it's in the shape of a tube. This is some of the more advanced, newer retractors in spine surgery are tubular, and they allow better tissue retraction. And you can see there's no bleeding because the disc itself is avascular, especially where we are in the disc, the inside of the disc. There's no blood supply. Avascular means no blood supply. There's only a few tissues in the human body that have no blood supply. If you're a Biden supporter, then your brain probably has no blood supply. I'm just kidding, all right? I never get political. I never get political. But I had to throw that one in. No, but the lens of the eye doesn't have a blood supply. So the lens doesn't have a blood supply, and the disc, the middle of the disc, the spinal disc, which is what we're fixing, doesn't have a blood supply. Now, some people act like their brains don't have a blood supply, but that's different. That's different. Of course, the brain has a blood supply, right? It's the most robust blood supply of any organ in the body. Besides, the heart is second, the kidneys are third, and the brain tissue needs lots of blood, lots and lots of blood. This is the tear, by the way. This is the laser, the blue thing, and I'm cleaning the tear, cleaning up the tear, cleaning up the tear. I don't ever get political, by the way, just because I don't think it's appropriate for me to get political. My focus is to teach about the spine and nothing else. Of course, I will talk about go-karting and racing and coral, because I do coral research, but those are really the only areas that I typically will talk about. Sometimes I'll talk about my kids as it relates to their school or hobbies, not hobbies, but I would say sports activities, since Arias is a professional race car driver basically at this point, and Ariana is on her way to being hopefully a Olympic volleyball player someday. We'll see. Okay. We are inside the annular tear, and we are at L45, I believe, correct? Next we'll do L5S1. Now, I've cleaned what I needed to here. I'm going to start backing my tube out, and that blue right there shows you where the tear is. The white is the annulus, and that blue is where the annulus is torn. So the Deuk laser disc repair, the surgery that I've developed and created, is the only surgery in the world that repairs this tear. There is no other surgery that's ever been described or published or in any book or chapter or journal that does an annular tear repair. The Deuk laser disc repair is the only one, and it's the first one, and it'll always be the first. Other people will copy this someday in the future, and that's fine. Remember, that's why we broadcast. We broadcast so that other surgeons can learn how to fix people's problems the way we do, because we believe our way is the best way. And if it wasn't, we would change our way until it was. Okay, so I'm just cleaning this tear up using the laser. The laser, some people want to know, what kind of laser you got there, Dr. Deuk? This is a holmium YAG, holmium, H-O-L-M-I-U-M, YAG, Y-A-G. YAG stands for yttrium, argon, garnet. Holmium YAG medical laser. Lasers are very commonly used in medicine, for those of you who don't know that. We're not the first people in the world to use a laser in medicine. They've been used long before spine surgeons use them. They've been used in ophthalmology. They've been used in for kidney stones, by urologists, kidney doctors. They've been using them. They've been used in general surgery, and they're being used in brain surgery, even neurosurgery lately for the last 10, 15 years, treating tumors and epilepsy focuses using laser. We used them on kids for spine surgery when I was a resident. Okay, stand by, wipe. Thank you. So we used the laser a lot when we did untethering of spinal cords when I was a resident at Shands Hospital back in the 90s. And Dr. David Pincus was the first one. Also, we used it to do what's called an endoscopic third ventriculostomy. That's where we open a hole in the drainage system of fluid in the brain, typically in young kids who had aqueductal stenosis, which is a blockage of the flow of fluid in the brain that causes the head to swell, causes hydrocephalus. We used to use a laser with endoscope in those kids to open a hole and allow the fluid, thank you Luis, to drain out properly. And that would treat their hydrocephalus quite effectively without having to put a shunt in. A shunt, for those of you who don't know, is a tube, like a long straw, very flimsy plastic, and it would drain the spinal fluid from the brain down into the abdomen usually. It could go to the heart too. It just depends on where you drain it, but most commonly it's the abdomen. Unfortunately, those tubes get obstructed. They stop working, and then the kids come into the emergency room and they got extra fluid on their brain. We call it hydrocephalus, and they could die from that. So the endoscopic third ventriculostomy is a tubeless drainage system. It's a natural drainage system by making a hole, which is brilliant. I didn't think of it. Somebody else did, much smarter than me. Anyway, we used to do those with a laser. So people think laser surgery in medicine is hocus pocus. That's nonsense. They're just behind the times. That's like saying, you know, when cell phones first came out, they said cell phones are hocus pocus. Just use a payphone. Standby laser. Payphone being a phone in a booth, like the ones from the old Superman movies with Clark Kent. All right. Unfortunately, the truth is there are advances made in everything, whether it's agriculture, whether it's industry, whether it's medicine, and there are always going to be people who don't keep up with those advances. And not so the key word is advance, but not every new technology that's introduced is an advancement, right? So I had a person online today who asked me, what do you think about this device that's being put into spines through the back? It's an interspinous device. What do you think about that? And that is a newer technology, and my answer was basically it's garbage. It doesn't work. Okay? Those interspinous process devices are garbage. They don't work. And the only reason they're being put in is they're being put in by doctors who shouldn't be doing surgery, because it's kind of a minor surgery that they may be able to get away with. Mostly pain management doctors that shouldn't be doing them, but they're doing it because they can make a lot of money off of doing it, even though they don't, really, the patient doesn't get any better. So to me, that's unethical. I don't do procedures that don't work. I don't care how much money I can make. I won't do procedures that don't work. My reputation and my commitment to helping people is far too important. I would never compromise it. I've had lots of opportunities to do procedures that don't work, but I don't do it because it's, like I said, it's not right. You're taking care of a human being and they trust you, and their life is put in your hand, and you need to be responsible and make sure you make the same choices you would for them that you would for yourself. So that's my philosophy, but a lot of doctors don't share that philosophy. Unfortunately, they're supposed to, but they don't. And they'll just put in whatever makes money. And I see that a lot. And that's one of the reasons why we do this broadcast. We do this broadcast to teach people to avoid those doctors and those procedures that actually don't work. So that's why we open these surgeries up and they're live, is so you, the audience, can ask questions. Okay? So I can answer them for you and the rest of the world, because the audience always has really good questions they ask. All right, we're finishing up L4-5. You can see a lot of inflammation. That's the end plate right there of L4. You can see those white fibers are starting to become a ligament. The annulus has pretty much been ripped all the way through from the inside to the out. The herniation that we saw with our discogram is gone. That's a little bone spur calcium right there. I'm zapping away. It turns gold in color. Okay, so this is right where that herniation was. It's gone. So I shoved it into the disc, and I've been zapping away at it with a laser and just taking it apart little piece by piece. You can see it shriveling up with the laser. Why do I use a laser? Because this laser, folks, the blue thing, is got a diameter of 0.5 millimeter. Think about that. 0.5 millimeter. 0.5 millimeter. That's less than the space between your fingertips when we make a very small space so you can barely see the light. Okay? If that laser is 0.5 millimeter and it's working nicely in this little space we've got, what do you think is going to happen when I use something big, like big and metal? It's not going to fit in here. That's the problem. And even when you do use something like a pituitary rongeur, it can't grab this stuff out. It just slips right out of it because you can't get the mechanical force you need with skinny little instruments. You can't get the compression you need on the tips to actually grab this stuff and rip it out. It just slips right out because there's not enough in the design of that instrument. It's so skinny, you just get too much bend of the metal. The metal is too flimsy to really grab on. All right, so just about done here with this disc. I think she's going to be very, very happy when she's healed up. All right, we're just finishing up at L4-5. We're going to do L5-S1 next. L5-S1 is pretty collapsed. So there's not a lot of herniation there to take out. But there's going to be a tear that needs to be fixed. And that's what we're going to focus on at L5-S1, is the annular tear. Just like we did here. This disc definitely had a bigger herniation. Any questions from our audience, Sean? Oh, we got a question. Good. What did he say? No questions. All right. Well, thanks for letting us know. I thought we did. My heart started racing.
Bit nervous?
Yes. Nervous. There's some fat right around the nerve in the epidural space. Remember, we're looking from the neuroforamen in. This is a view that 99.9% of spine surgeons never see in their entire career. Why? Because they don't know how to do this very advanced type surgery. This is called endoscopic transforaminal spine surgery. It's very hot, very new, and it's the future of spine surgery for all herniated discs. However, unfortunately, most surgeons have no clue how to do it because they were never trained to do it. I wasn't trained in residency how to do this surgery. I had to learn. Oh, you guys forgot my wrist one. That's why my foot is getting wet. I wasn't trained to do this in residency. I had to learn. I had to go overseas to learn. You're catching my glove. Okay, good. That's good. Okay, I had to go overseas to learn. I had to leave my practice. I had to leave, stop making money. I had to put making money aside until I could learn how to do this. I had to go get trained. You don't get paid to train, by the way. You lose money when you go train. So unfortunately, if this surgery is not taught in residencies where surgeons are being trained, they're not going to go and learn how to do it afterwards. Now, some of us can do that. Some of us are really good at learning. If you have a really good understanding of the anatomy and the physiology, you can actually learn this surgery very quickly. I learned it very quickly. But most doctors need a year of training to learn how to do this surgery. A year of training. A year of doing spine surgery of this type. Huh?
No, I'm taking the first.
So for those spine surgeons out there that are watching, that are interested, if I'm still alive when you're watching this, call up Deuk Spine Institute. I'm interested in training surgeons to do it if you're interested in learning. Now, you do have to have a license to practice medicine in Florida. You can't just be a foreign medical graduate and no license and come over here and me train you. I'm able to do some limited training of foreign graduates, but if you want to learn how to do the surgery properly and actually do it yourself, you got to have a license to practice medicine, and you have to have a surgical background or training. Okay. All right, just about done. 30 seconds, and then we're going to get on to 5-1. There's that last part of the herniation and annular tear laterally. For those of you watching, this surgery requires you to restrict your activities afterwards. I have patients who don't listen. They go out and they feel so good, they just start lifting things or bending at the waist. Can't do that. You're going to re-injure your disc. You'll re-herniate. Our re-herniation rate is about 1.1%, slightly higher than 1%, probably around 1.1% at this point. So, but virtually every single case, there's been something the patient's done they shouldn't have. Okay, the nerve root should be right there. There it is. You see the white thing? That's the nerve root. So that's in the foramen. The disc herniation's gone completely. Laser off. So we'll suck the water out. There it is. A nice dry foramen. Scope off. So no medicine, right?
Yeah,
Oh, well, normally we put a little bit of steroid to reduce some of the irritation of the nerves and stuff that we are treating right in that area, but we can't do that. This patient, unfortunately, has apparently a reaction to the steroid. Go ahead, watch. You got to move your face away. You cannot stand there and let somebody do that, okay? So go ahead and get the fluoro in. Let's go get the fluoro in, please. Jordan, you don't need to be one-dimensional. You can be three-dimensional while you're bringing the fluoro in. I've seen x-ray techs push the base in, rolling it in as they're turning it and dropping it. Okay, it doesn't have to be this, then this, then this. It can be all done fluidly at one time. That's what you should work towards. All right. Is that your shot? It's too far south, right? So let's get north. Shot. All right. Put pressure here, Sam. Right there. Not too much, just a little bit. No, too much. Shot. Perfect. Okay. We're ready to go and do L5S1. Make sure you don't pull your guide wire out while you're taking your needle out. So Cam, yes, sir. You want to be an orthopedic surgeon, right? Shame on you. I'm just kidding. Are you going to try to do spine, or are you going to do something else? I like spine. Don't say I like spine. That's like, you know, a girl saying, are you going to ask me out? And you say, I like you. You didn't answer the question. I like to say sports. Yeah, so sports. So what, you want to do upper extremity? Shot. Huh? Knees? All right, I'm not seeing well, Jordan. You got to be fixing that. I shouldn't have to tell you. So I think you got to fix this. I think this side has to come down. And I think you may have to wag a little bit. You can see a double shadow on the back of the vertebral body. I think you just made it worse, but go ahead and shot. Okay. Now right there, maybe better. Okay, so there's still, I think you're a little too far north, but I don't know if you could wag that out and make it better. Just lay still, you're doing great. Shot. You're doing fine, everything's okay. You see how your pedicles are superimposed with a wag? but they're not. You got to bring your side down. That's what I told you before. Shot. Let's try that. You're doing fine. Everything's okay. Yeah, I think that's better. Why am I not seeing the guide wire? Shot. All right, there it is. You're doing okay. Just lay still. You're doing good. Shot. Shot. All right. That's got to be good. Good. We weren't trapped too much. Shot. I think that looks fine. It's just the reason why we're not getting a great picture, folks, mostly is soft tissue issues. The more soft tissue that is present between the fluoro emitter and receiving panel, the less quality, less resolution you're going to see. Shot. 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 That's about as good as we're going to get it. Let me have the tool. You got to give it to me in a way I can hold it, Sam.
Okay, we're just gonna put it this.
Thank you, Jordan. Yeah, pull it out. All right. Yeah, laser. So there's the herniation right there. The tear and everything. All that, see that stringy stuff? Okay, come on. All right, let's talk about it. You see the yellow thing that looks like an octopus head? That's a piece of fat, but come on. But it's scarred. All right? That's all epidural fat. I'll be done in 5 minutes. So now this thing here is scar tissue, right here. That's from the herniation and inflammation, just massive, massive inflammation right around the nerve root. That's actually attached just below the nerve root. So, all right, that's from inflammation. Then you got the end plate, which is that orangey, reddish color over there. That's the L5 end plate. Then you've got the S1 end plate on my left at 9 o'clock. But the blue thing right here, that's the herniation. That's the annular tear. That's really what we're after right there. That's what's going to take the pain away. I hope somebody eventually learns this technique. Because if I die and it dies with me, it's going to be a shame. Four minutes. Now why? Whew, all that, look at that, just crusty garbage. Sorry, not garbage like the kind of garbage you think of, but it's just all damaged disc. Severely damaged, severely inflamed. For years. This is not something that happened recently. You can tell by the structural changes that I'm seeing that this has been going on for a long time. This injury to the herniation, to the disc. Here's a bone spur. Okay, so let's see if I can target that medial component a little bit better. We didn't get a great discogram on this because of all the scar tissue. But what I'm zapping right now is the part of the disc that's causing the pain. 2 minutes, we're done. 2 minutes. You guys ready? Blood pressure's been good? Ooh, it's a little high, huh? All right. Well, I promise you, epidural hematomas are not things we want to deal with here. So we got to keep the blood pressure under control. It's very serious. I don't ask for things unless I really, really mean it. I'm a minimalist, okay? Just so you understand. It's my personality and nature to be a minimalist. I do the very minimum, but I'm very complex because with these types of surgery, you need lots of control over variables to make a successful outcome. So it's odd that I'm a minimalist who's so demanding. Just about done. 30 seconds. That's just about done. I'll show you the L5 nerve root. This will be the right L5 root. It's just a lot of scarred up fat right there. Alright. Yeah. Let me have a grabber. Take. See if I can grab that little hunk out. Oh. Take it. Oh, we're pretty much done. All right, let's take a look at that nerve. See how close we are to the nerve? That's a nerve. Hey, there's the covering of the nerve. We're literally retracting it. And since we don't have any, okay, let me have the laser one more time real quick. 30 seconds. Done.
All right. Nice on, please.
Scope off.
I take care of that.
I don't like the fact we can't do anything for the irritation that I'm causing with the surgery. Good news is I don't see anything like a hematoma. Pressure here, please. Yep, hard pressure. All your guys, let's get it done.
Yes.
Thank you. Good work, everybody. Let's work on the blood pressure control. Did you work the laser?
Yeah.
Nice job, Cam. All right, good teamwork, everyone. I've got one Ray Tech off the field in the garbage. Any questions, Sean, from our audience, or do they know everything? Anybody know what the word is for knowing everything? Anybody? The word for knowing everything. EBL 1 mil. Omniscient. Right? All knowing. Only God is omniscient. Okay. Well, I hope you enjoyed the surgery. I'll head over to the conference room and talk to you in a minute. I'm going to go check on our first patient first, the cervical fusion. He looks like he's awake, probably ready to go home soon. Thanks, everyone.